Quiet. Dr. Saurabh has promised us to wind it up in 15 minutes and then we will start the question and answer session.
Sure. So, good evening everyone, warm greeting from Ganganam Hospital, and it's my pleasure to be giving my first talk over here. My topic was role of laparoscopy, basically laparoscopy in gastrointestinal cancers. So, as we all know that cancers itself is a multidisciplinary management. Cancer itself is a multidisciplinary management which involves radiation oncologist, medical oncologist, gastroenterologist, everyone from the medical fraternity and surgical team itself. And apart from them, there is a lot of ancillary care. So when we talk about surgical management, there are, now we have switched to open techniques which are traditional cancer surgeries, minimal access which includes laparoscopy and robotics. So my pursuit was more into the laparoscopy and robotic surgeries. I was going to talk more about laparoscopic surgeries today. So as we all know that, we are heading towards as a tertiary care center into the organ-specific cancer surgery practices. And when we talk about the evidences, if I would have been giving the same talk before 10 years when I was studying, then I felt that there are certain not evidences that to prove. When we used to sit in the forums, people used to question about whether we should use the laparoscopy or robotic surgeries in cancer surgeries or not. But it's astonishing, I tell you, it's really astonishing the number of scientific papers, the number of RCTs, the number of trials which have come and prove organ-wise that it is really, they have grade A recommendations. So what I mean by grade A recommendation here is that, grade A recommendation is that when you can recommend something with the support of evidence of multiple RCTs, systemic reviews and meta-analysis. So if you talk about organs in the GI, now if you talk about colon cancers and rectal cancers, they have grade A evidence that we can safely use laparoscopic surgery with same results and outcomes. When we talk about stomach cancers, they have the similar outputs. When we talk about esophageal cancers, the recent meta-analysis done in Annals of Surgery, which was published in 2022 in Feb, which is said to be groundbreaking paper of all times, has proven that it shows 15% lower mortality and morbidity with minimal invasive esophagectomies. So nowadays we are doing laparoscopic and minimal invasive esophagectomies. I had certain videos to show you. And third was role of laparoscopy in HPV cancers. So there is a grade B evidence on that because it needs a lot of skill levels and a lot of patience to adopt doing a laparoscopic or robotic surgeries in Whipple's procedures like pancreatic head procedures or distal pancreatic procedures or liver dissections. So still we are in a phase that the higher tertiary centers which have good evidence can we are routinely doing now laparoscopic Whipple surgeries or laparoscopic distal pancreatectomies, laparoscopic CBD excisions, but still there is a grade B evidence on that. So I had certain videos on that. If we can switch to certain videos, can we play? ये तो अपनी नहीं, it's not possible.
डॉक्टर सौरभ, आपको पेशेंट जो है आपके क्लिनिक में रेफर कर सकते हैं?
बिल्कुल सर, बिल्कुल कर सकते हैं, कोई इशू नहीं है. Absolutely, there is all facilities of endoscopies, colonoscopies. We are tied up with lot of diagnostic centers, all topmost diagnostic centers for scanning and all. So we are doing everything in the clinic. We make the diagnosis, we prepare the patient here and take the patient to the Ganganam Hospital and we operate there.
Sir,
so most of the cancer surgeries
I'm sure you are doing bariatric surgery also?
Bariatrics I do less. I more focus on laparoscopic cancer surgeries. I have done a lot of bariatric surgery. Now Dr. Prakhar is with me, so he is taking care of bariatric surgery.
Okay.
So and Whipples we do almost 4 to 5 cases a month, and we do lately I have completed almost like more than 10 cases of laparoscopic ripples. So excellent results I feel personally, because we can discharge the patient almost on 6th or 7th day. And why I feel, minimal access cancer surgeries has progressed in the last 10 years, because of the excellent technology we have right now. Because of the 4D, 4K visions, and we get excellent visualization of the structures, excellent, magnification to visualize the structures and dissect the arteries, dissect the vessels, dissect the structures all around. Then we have endo cartridges, endo staplers, which help us to really do the anastomosis and division of the organs in situ. So we don't need to even give a smaller incisions or a bigger incisions to even extract the organs. Generally, I use a fenestrine incisions, as most of the gynecologists use, to extract the organs. In fact, colorectal I have progressed to the natural orifice specimen extraction, where in upper rectal and sigmoid tumors we are dividing the rectum, and we are putting a protection bag, specimen bag, which has 2 rings, and we take the specimen out of the anal canal from there itself, and then we put a stapler across, and then put a do a staple anastomosis under vision. So basically, when you look at the patient, it has only 4 ports, like a laparoscopic cholecystectomy, and the entire laparoscopic anterior resection has been done. So same is with laparoscopic right hemicolectomy. We generally need 3 or 4 ports to complete it. Ripples, I had all those videos and stuff, which unfortunately not playing up, but it needs only 5 ports to complete the entire lap ripples. Esophagectomy has excellent results, because I feel personally, when you give a traditional thoracotomy incision and abdominal incision, what happens is, in the post-op period, the most of the morbidity and mortality used to happen because of the pulmonary complications, because the patient cannot breathe properly when you have a good long incision over the chest. So once you do a minimal access surgery, you can see the patient next day sitting in your high dependence unit, and he is breathing by himself once he is extubated, and he's so comfortable. And it's extremely, I will say, pleasure to see your patients doing after cancer surgeries on 2nd and 3rd day themselves asking that when we can start eating, we are feeling hungry, and they start walking around on the 2nd day. The mobilization, the post-operative pain, the post-operative recovery is so fast that they can easily, by 3rd week, we can switch them to the medical oncologist for their adjuvant treatment. So that is the best part. There is no, there is no big cuts, so there is no chance of wound infections or incisional hernias in long term. So it's almost on the 3rd week that we refer our patients back to their physicians for further adjuvant treatment, for medical treatment. So in short, I feel that personally I have seen in 10 years I worked with one of the best centers across the world. I was in GEM in Coimbatore, which was like a Makkah Medina of laparoscopic surgery and robotic surgery, where we used to do almost 6,000 cases a year, only GI surgeries. And then I switched to Taiwan, where I was doing almost like more than 150 colorectal dissections a month. So what I observed, but changed my perception from open to laparoscopic, because I was doing my post-graduation in Delhi. I did my senior residency over here, and I felt that it's a thing, it's a future, it's the present right now. So and the results, pathological results, which I was going to show, it is excellent. For colon, if you look at the annals data, which I was going to show you, annals, there has a recent publication in 2021 in Annals of Surgery, which compared lap versus open meta-analysis for all coronary dissections and rectal dissections. So what they showed was, apart from the naive benefits like early recovery, all those things which are inherent of laparoscopy, they found that the pathological complete mesocolic excision, the pathological specimens were 15 to 18% better when they conducted a study over 15,000 patients. So, in fact, if you look at the Western data, the 2/3 of the centers have switched to the minimal access colorectal surgeries when you look into the last 10 years data. And esophagus still in the evolving phase because it's a technically difficult surgeries. Now, esophagus, there is a data of Netherlands and entire European county that there is a 13,500 patients which they have done almost 22% of minimally invasive esophagectomy, and rest of the 78% was open esophagectomy, the traditional open esophagectomy. And they found that, interestingly they found that, apart from being proven pathologically and everything, the morbidity and mortality associated with the minimally invasive esophagectomy is almost 15 to 18% less over the period of 3 years and 5 years, as we calculate our disease-free survival period of 3 years and overall survival period of 5 years. So it came out good. Still, HPV surgeries still under the very skillful surgeons and very high volume loaded centers are doing it. Yes, it's still in the clinical scenario that where certain studies are in through the randomized controlled trials. But there are certain randomized controlled trials already there which have recommendation which is grade B right now. So I'm so sorry again that
No problem. Don't feel sorry.
We are not doing it, but there are certain I know oncosurgeons which have started transoral robotic surgeries and transoral surgeries, even thyroidectomies. In fact, I tried transaxillary thyroidectomies. But I have not done, honestly, I have not done in cancer right now. So, but yes, I have seen that people are doing T1, T2 lesions and most of the T1, T2 lesions which doesn't require radical dissection, they are doing in transoral cavities. Yes, absolutely scarless, absolutely scarless. In fact, in there are, when we talk about this, there are certain limitations to the minimal invasive esophagectomy, like when you talk about metastatic disease or a locally advanced disease where there is a multi-organ involvement, where you cannot take the huge in toto specimen together, like a CS stomach involving a spleen or a distal part of pancreas, where you need a radical gastrectomy and distal pancreatectomy and splenectomy. Definitely, it's not feasible with minimal access surgeries. So there are certain limitations to that, and I have strongly observed that when you this is another forum, but when we talk in the surgical forums, but I strongly feel that the people who are trying to adopt to the minimal invasive cancer surgeries, they should be adopted in high volume centers or the centers which have entire facilities, which have good backups, anesthetist backups and ICU backups. So that is one. Thank you so much.
I think we must hand it over to Dr. Saurabh. All questions directed to Dr. Saurabh on gastroenterology. Now, yes, Dr. Sen, sir. Dr. Sen.
So, thank you very much for a wonderful talk. Extempore. Carcinoma esophagus. When we were in Sabdajan, we lost one of our professors to that in 3 months' time. Professor Manmohan, I still remember. And how much has the prognosis changed? And how much are you able to do that if the patient is there with some preliminary symptoms? We lost another patient in our own residential colony 5 months' time only. Though she was getting treated at Rajiv Gandhi, her initial presentation was some kind of a earache. I mean, I don't know whether that was a sign of metastasis or something, but later when we discussed later, that was the presentation. So, I mean, if you are looking at the classical signs of dysphagia to liquids and not solids, and other things happening over a period of time, how much is the prognosis, changed vis-a-vis the surgery and the chemotherapy or radiotherapy, whatever it is?
So we want to, I feel like we will cut it short at what do you feel that you want to ask me, what is the prognostication change in last with the advanced chemotherapy and immunotherapy?
Let's say 3 decades, last 3 decades.
Last 3 decades. I will say that, if you read the papers around 2000, you will find when I was studying my post-graduation, the morbidity was around more than 50% and mortality was reported as 10 to 30% for any esophagectomies. Now the standard of, if you read it in 2020, like this paper which I quoted, they show that mortality, accepted mortality for any cancer center for any esophagectomy is around 2 to 5% and morbidity is only 10 to 20%. So your case selection has to be absolutely good. As you mentioned that one of your patients having a CA diagnosed with CA esophagus with an earache, it means straight away that you have involvement of nerves. So once your nerve is involved in mid-thoracic region or upper mid-thoracic region, you definitely need to target for neo-joint CTRT, and you should be very liberal with PET-CT scans when we are planning for a CA esophagus surgery. Nowadays, if you ask us, when we plan our surgeries for any cancer, we always see that if the patient is not going to survive doing surgery for 2 years, there is no point of doing any surgery. Let him do a palliative care, let him get some chemotherapy if he can. If he can't, give him some palliative care. There is no point of torturing him physically as well as financially as well as mentally. The patients who are coming with locally advanced disease which don't have a good quality of life after surgery. So one has to be very selective about selecting your patients. And the good thing is, nowadays if somebody is practicing oncology per se, it works like a mathematics. So there are protocols which say T1, this you have to do, T2, T3, you have to do it like this, T4, you have to do like this. Even your medical oncologist and radiation oncologist or a gastroenterologist will prompt you to do like that way only. So if a gastroenterologist feels that the patient won't be good after surgery, he won't refer it to me even. So they feel that it's better that we could do a palliative stenting. I'm sure Shubam is doing a lot of palliative stenting. I discuss with him quite often. A lot of cholangiocarcinomas don't present early. More than 50% of cholangiocarcinomas present generally when they are metastatic or locally advanced, where we don't have a surgical option itself.
So, as a practicing clinician, if you are looking at the entire spectrum of gut malignancies, which is the worst that you can look at? Is it still carcinoma esophagus or somewhere else in the gut?
I feel still the worst is CA pancreas and HPV cancers. You can't diagnose it. Even liver cancers are presented with metastasis.
I would like to ask you.
Breast are colon cancers. They still have very good prognostication. They are diagnosed early. Your patients will somehow have some bowel complaints. Somehow. Once the lesion starts increasing, right sided will be more presented with melena, weakness, anemia. So, and left sided will start presenting with obstructive growth, stress bleeding and all those stuff.
I would like to ask you a question, sir. You have wonderful experience. Unfortunately, we couldn't see the slides. I have a suggestion, Dr. Saurabh, though. Kindly record your talk with your slides. We would send it to everyone in the group, and we will also put it in the YouTube. Sir, I have a question. The entire GI tract, the malignancy does not behave the same, and you have yourself mentioned it. I sent a patient to Dr. Shubam pre-COVID. No, pre-COVID, Mr. Chima, and he diagnosed him as a case of CA colon. Now he is my regular morning walk partner. And he told him that get his surgery done as soon as possible. Now 4 years later, that patient has still not been operated. Only symptoms are mild obstructive symptoms during defecation. He continues to have anemia, hemoglobin between 8 to 10. He comes for a walk every day in the morning, even during winter. This is one scenario. The another case that I sent to him yesterday was when he did a endoscopy, and he would describe the findings. This was CA, is most likely CA esophagus. Biopsy has been sent. He came to us 4 months ago. I advised him that you get an endoscopy done, don't do anything else. He didn't have money. Now he came, he took some money from somebody and said, now I have some money, sir. Kindly get my endoscopy done. So I got his endoscopy done. This is esophageal growth. Dr. Shubam will describe. He could not go through the growth itself.
Thank you so much. So, but I would say that if Mr. Chima has been operated, let's just see that, and God forbid me for saying this, what is the time period he'll survive with that malignancy in situ? Right? In 4 years, he might have something in the next 1 to 2 years. And what is the 5-year survival without surgery? With CA colon, it is prudent to get a surgery done because 5-year survival with good surgery is almost 100%.
Almost. Yes.
In resectable cases.
All I want to say is that two different cancers in GI, they behave extremely differently. Here is a case in 4 months, this man is almost about to go. I asked Dr. Shubam, he said 3 months, 4 months, maximum 5 months. And here another case of CA colon. He and me asked him to get operated, and this fellow is after 4 years still coming for a walk. He says, Doctor, operation क्यों करा?
So see, CA colon is a very wonderful disease. Why? Because it gives you, if you follow the American guidelines of screening colonoscopy at 50 years, you will diagnose so many polyps and you will remove them when the base does not have any malignancy. So you can remove pre-malignant lesions. In CA esophagus, that is not the case. In hepatopancreatic biliary cancers like CAGB, which is the most common GI malignancy in India, and in North India it is way high, right? And CA pancreas or cholangiocarcinoma or like what we call periampullary CAGB, these people present, almost all present when they are not resectable.
Almost more than 50.
So in all these patients, you cannot even resect. And you see the number of lab choles these surgeons do, and it is on the thing that it might develop malignancy. So harboring a hepatopancreatic biliary malignancy is something which is almost six months survival is without in metastatic case 6 months survival is 5% in hepatopancreatic biliary. So in such CA esophagus in a patient, I did search with a patient last 2 days ago on Monday. Right in the upper GI, 35 centimeter of the incisor teeth, there was an ulcer growth which was completely encircling the lumen. Scope not negotiable, patient not able to take liquids. So I asked sir to get a feeding endoscopy done because by the time even we decide of chemo, radio or resection, if that is possible, patient won't survive due to malnutrition. So there has to be, the management depends upon the site of malignancy. And GI is so advanced, it's such a long system that we cannot compare a CA esophagus to a CA stomach to a CA small intestine to a CA colorectal to hepatopancreatic biliary. They are completely different. What you call, we find surgeons who only operate lap pimples, and that is what the area they operate in. So they are the worst malignancies to have are hepatopancreatic biliary malignancies, particularly the CA pancreas, the cholangios and the CA.
Thank you, Dr. Shubam. Dr. S.P. Singh, sir, has a question.
Thank you, sir. Sir, I have a very small question regarding the dysphagia. Large number of the society having this problem. When they approach the doctors, gastroenterologists, whatever may be, they say, दारू पीते हो, सिगरेट पीते हो, अचार खाते हो, ये खाते हो, वो खाते हो. तो कहते हैं सर मैं तो कुछ करता ही नहीं. फिर भी मेरे हो रहा है. फिर सब्जेक्टेड टू एंडोस्कोपी. आपको तो भैया गर्ड है, वेरी कॉमन, वेरी गर्ड है आपको तो. अजी गर्ड है तो मैं क्या करूं? क्या ये बंद कर दो? अरे तो मैं लेता ही तो बंद कैसे करूं? जब मैं ये लेता ही तो बंद कहां से करूं? This is my question 1. Number 2, when these people subjected for the investigation, I don't know. There is an investigation, they put the tube in the nasal and gastric, they drops, they record the peristalsis of the, yes. They say upper 1/3 of this is movement is very slow. Last is normal. Then what is gut? Why this gut is there? If upper 1/3 is movement is slow, everything is normal. Why you say gut? This is my question.
So I think there are just a minute. I will summarize what sir is trying to ask. First of all, no, please be here.
Sir.
let us give honor to everyone who asked question. Sir, I think basically, is there any relationship of alcohol and tobacco to CA? Can you answer that first?
Yes, sir. So indirect alcohol is directly causative to squamous cell carcinoma esophagus, not to adenocarcinoma esophagus. Indirectly, alcohol can cause GERD and cause distal esophageal malignancy. So smoking is directly related to SCC esophagus. But the point what you are saying is absolutely taken, sir. So nobody has completely understood the carcinogenesis till date. So we have environmental factors which are under our control, and we have genetic factors which might express in one generation after 1,000 generations. So a person can have HCC, hepatocellular carcinoma, at 12 years of age, without having hepatitis B, without having cirrhosis, without having anything, without having alcohol. A person can have CA esophagus at 6 years of age. That is completely reported because environmental factors are just a part of the whole pathophysiology which no one has understood and no one believes to that we will understand till a good amount of time.
Dr. Shubam, is smoking related to CA pancreas?
Yes, sir. We don't find non-smoker CA pancreas. If you see CA pancreas non-smoker, that has to be related to hereditary pancreatitis or SPINK1 mutation, PRSS1, N21, N29I or R117H.
Most likely genetic.
Yeah. So if you are seeing a sporadic CA pancreas, you generally don't find non-smokers with CA pancreas.
The females
No. Answer completely. Is achar related to cancers?
So salted smoked fish, salted pickles are definitely associated to CA esophagus.
Okay. Stomach also.
That is first part of no, sir, please bear with us. Sir asked about a very important question of esophageal issues which we find, and these issues can be functional and these issues can be organic.
Yes.
Right? We find these issues to be organic in people with diabetes and with lot of people with psychiatric illnesses. We have a very eminent psychiatrist here, Dr. Manish Sarkar. Okay, Dr. Manish, please sir, rise. And do you find cases in your practice where you see people coming with esophageal motility disorders with, let us say, obstruction here in the chest? Can you give this? Can you give to Dr. Manish with GI symptoms, upper GI symptoms, psychiatric patients?
Sir, I definitely do that. Rather, I would like to classify two categories. First thing is that since a de-addiction specialist, I treat a lot of patients of addiction and all. So they come with acute pancreatitis, chronic pancreatitis and all. And the predominance of depression and anxiety is very high. So that definitely is a neurotic spectrum disorders. But irrespective of that, GARD and other pancreatic issues, I do see high comorbidity of psychological issues. But mainly it is a neurotic spectrum, very less in psychotic spectrum.
Thank you. Thank you. Give it to Dr. S.P. Singh, sir. Sir, any other question you want to ask?
Sir, my initial question I asked, patient is not taking any alcohol, smoking, tobacco, chewing, gut or नहीं, but he is having gut. It is not answered. Number one. Number two तो बोल गया ना?
कोई बात नहीं,
आपका क्वेश्चन बहुत अच्छा है.
Just a minute, sir. No.
अभी याद आ जाएगा सब पूछ
कोई बात नहीं. Dr. S.P. Singh sir has a very good input, and I mean you would remember that famous song from Three Idiots. Confusion है, solution कुछ पता नहीं, solution जो पता चला तो
सर solution यहाँ से मिलेगा.
Question क्या था पता नहीं.
सर मैंने पूछ लिया.
सर आपने क्वेश्चन पूछा, मैंने उसकी तारीफ की सर. मैंने जो आपने कहा कि मैं भूल गया, मैंने उसकी भी तारीफ की.
नहीं, उसकी जरूरत नहीं थी ना, मैं याद आ जाएगा तब तक.
सर हमने कहा
याद आ जाएगा तब तक, अभी याद आएगा.
एक मिनट सर. I think now we will proceed and give it to Dr. Tulsi sir. Dr. M.L. Talwar
सर मैंने हमारे यहाँ पे दो ग्रुप हैं, मैं वैसे बता दूं. एक है नॉन तुलसी ग्रुप, एक तुलसी ग्रुप. तो तुलसी ग्रुप में मैं छोटा सा एक इंट्रोड्यूसर हूँ. तो मैंने तो सवाल ही नहीं पूछा था, इनको इंट्रोड्यूस किया था. मेरा सवाल एक लास्ट है आपसे, वो बड़ा इम्पोर्टेंट है. कि क्या हमारे यहाँ पे स्ट्रोक स्पेसिफिक एम्बुलेंसेज हैं? If it is there, we want to know the number because we at times have ambulance means ambulance. वो कई जगह पे 911 पता नहीं यहाँ पे हर हॉस्पिटल का अलग नंबर है. Any stroke specific ambulance if we have, please let us know.
102 पे कौन कर रहा है?
एम्बुलेंस
Sir, we have the emergency number, PSI emergency number.
Stroke specific नहीं.
Stroke helpline must be.
Sir, GI questions. if you don't mind.
सर मेरा क्वेश्चन तो आया नहीं अभी बता सकता
मेरा एक इधर से hyperbaric oxygen has it been used for stroke? Please.
It has no role whatsoever.
So, Dr. Bhaskar, talking about contraindications, see, for lap surgery would be what?
Dr. Saurabh.
Dr. Saurabh? Okay. Dr. Shukla.
Dr. Vatsya Shubam and Dr. Saurabh Bansal.
Dr. Bansal.
And Dr. Shubla.
आज reaction हो रही है इनकी.
Okay. Okay.
शायद समझ गया है तो याद रखो.
So, sir,
Go ahead, sir.
talking about the most common relative contraindication is reoperative abdomen.